Hello, everyone, and thank you for joining today's webinar. This is the 10th webinar that Pallium is hosting on topics relevant to healthcare teams who are actively leading the responsibility team. These webinars are made possible thanks to a restricted contribution from Boehringer Ingelheim and their Bridging Hope initiative. Today's webinar is entitled Essential Conversations Utilizing Advanced Care Planning and Serious Illness Tools During COVID-19 and Throughout the Patient Journey. As with previous webinars, we have assembled a group of experts from across the country, and each week is through a series of slides and contributing to the dialogue throughout this webinar. In terms of some of the housekeeping elements, we would like to solicit your input and questions throughout the webinar, which you can do by using the Q&A function at the bottom of your screen. And by contributing in this fashion, you are helping to the collection of knowledge that will be generated over the next 60 minutes. So thank you in advance for doing that. We'll be collecting and collating this information for future reference, and this is being recorded. In terms of the presenters, so I'm your host for today's webinar. My name is Jeffrey Moat. I am the Chief Executive Officer of Pallium Canada. Our moderator today is Dr. Gallagher. And Erin, where do you introduce yourself?
Yeah, I'm an assistant professor in the Department of Family Medicine at McMaster University. I work in family medicine. I'm also a palliative care consultant.
Great. Delighted to have you as our moderator, and we have several other presenters. Cari, over to you.
Hi, everyone. Thanks for joining today. I'm Cari, and I work in Fraser Health in British Columbia as a lead for advanced care planning. It's a job I've had for about 15 years. I also teach at UBC and got my hands on all kinds of other pots, but those are the big ones.
Great. Jeff.
Good evening, afternoon, wherever you are in Canada. Jeff Myers, I'm palliative care physician in my 25th year, which I'm very excited about, and running the Bridgepoint Palliative Care Unit here in Toronto, and an associate professor at U of T, and very happy to be with you this evening.
Thanks, Jeff. And over to you, Jess.
And I'm Jessica Simon. I'm a palliative care physician as well. I also work as a physician consultant for advanced care planning and goals of care at Alberta Health Services in the Calgary zone of Alberta. Greetings.
So great to have all of you on board. In terms of declarations of conflicts, well, first off, Pallium Canada, we're a national nonprofit organization. We're founded in 2000, based in Ottawa. Pallium equips healthcare professionals, healthcare organizations, and communities with the skills and knowledge to provide palliative care earlier, more effectively, and more compassionately to all Canadians. In terms of conflict, I am an employee of Pallium Canada. Erin, I don't believe you have any conflicts. Cari, Jeff, Jessica? No conflicts there. Over to you, Erin.
Okay, so we have 3 learning objectives for today. Upon completing this webinar, you should be able to understand definitions and concepts of advanced care planning and serious illness, be familiar with COVID-19 adapted resources, and better understand how to integrate conversations into the moment care. Sorry for that. The slides will be available on the Pallium website with the rest of the webinars that have been done. And Jeff, you said this was what number of webinar today? I think he said it was the 10th.
This is number 10.
Yeah, which is amazing. So it'll be where the rest of them have been uploaded, and I'll hand it over to you now, Jessica.
Thank you. So COVID-19 has obviously had a profound impact on all of us and all that we do. And one of the more positive aspects, perhaps, is an intense interest in advanced care planning. You've probably seen headlines like this. And now more than ever, there's an opportunity to talk to our patients, talk to our families about our own wishes, and make sure that people know what's important to us should we lose that opportunity to speak for ourselves. Some of the headlines continue to perpetuate this idea that advanced care planning is just for end-of-life decisions, but we hope to share with you this evening that really advanced care planning is about letting people know how you want to be looked after right the way through your life, and not just at end of life. If we just go to the next slide. It's one of the best ways to show compassion in these strange times, and I was interested in the byline of this article from CBC that said, you know, family members are wrong about end-of-life care preferences roughly 1/3 of the time. And for healthcare providers, it's more like half of the time that we're wrong about guessing what it is that's important to our patients and how they might want to be treated. So I thought I'd do a quick poll at this time just to ask you, just to get a sense of where you're at with your own practice. What's your level of comfort with these kinds of essential conversations? And you'll find that poll feature hopefully intuitive. So it looks like we're speaking to an audience that's already had quite a lot of experience. And so as we go through this evening, I'm hoping you'll pick out some tips maybe of how you might teach this to others, what you might want to help learners in your areas know about, or other colleagues know about if they're less comfortable than you are. And then I always, when I listen to Cari and Jeff, I always take away something new that adds to my own learning as well. So we'll move straight on. And we're going to base this around a case. So talking with Mary. Mary's a 73-year-old grandmother. She lives with her husband at home, and she was hospitalized twice last year with exacerbations of heart failure. And due to her age and her other comorbidities, you would identify Mary as being at risk. If she was to get a COVID-19 infection, it might leave her very seriously unwell. So that's Mary, and I'm going to hand over to Cari now to walk us through advanced care planning. Thanks.
Thank you. So we thought that we would start off by just reminding many of us out there, I'm sure already know this, but we do have an international consensus definition that Rebecca Sidori and various colleagues around the world put together in 2017, I believe. There's the year. And I think that there are, two things to really remember about this definition, and that is that it is a process, and it is something that should really start when we're younger. But the things that we think about and we talk about when we're healthy adults or we're healthy and younger adults are different than when we get diagnosed with chronic illness or a serious illness. But wouldn't it be great if ideally out there people were actually thinking about things like substitute decision makers when we were healthier and when we were younger? And certainly the goal of advanced care planning is to help make sure that people do receive the care that really matches who they are as a person, their values, their goals, and their beliefs. And I think one of the things that we often say, at least out here in British Columbia and Fraser Health, is that certainly that doesn't mean that everybody who wants a particular treatment always gets it. Unfortunately, that in the real world isn't always the way. But as we engage in advanced care planning with people, themselves as well as their families really start to understand all the nuances of medicine out there and different treatments that may or may not be available to them down the road. Next slide. This slide is to say, advanced care planning is the overarching process. Certainly, I think that many of us in Canada see it like that. It's the overarching process, and in that bucket, we've got a lot of different tools. And we do have conversation tools for us for advanced care planning for a lot of that upstream work. We also have tools that are around serious illness conversation that we'll be talking about today is really for people who have, a 1 to 2 year prognosis. But we just wanted to touch a little bit on some of the tools that are available out there in both of these buckets, touching a little bit on advanced care planning first. Next slide, please. Thanks. So as I mentioned, and I think as many of us on this call likely know, there are a variety of different tools out there. Hopefully we're not confusing everybody with all the different tools and all the energy we have there creating things. But certainly for healthcare providers, there are a variety of tools. I've just chosen 2 sort of snippet shots to put up here for you. And when I look at them, one of them is from Fraser Health here in British Columbia, and the other one is from Ontario. And what I notice about these 2, as well as the other ones that I'm aware of across the country, is that they're different, but they're very, very similar. We're really talking, I think, the same language. So if we think about our person, Mary, that Jessica introduced to us, it could be that that Mary, we would be having some conversations with Mary along her life journey. And we may be talking to her, maybe the physician's talking to her, maybe the person, the nurse, the social worker at the heart function clinic has touched base with her along the way really early on in her journey of health, and have said to her, we just want to make sure that you understand what's going on with your health, and to really help Mary understand at a very early sort of onset of her heart disease of what's going on with that. We want to make sure that Mary understands the substitute decision making and what that might look like down the road, and the tools that are available to Mary and her family to make sure that she's engaging and speaking to people that are important to her and her family. So just put those two resources out there to say there's lots of resources out there that really help us frame advanced care planning really early on. So those are just two examples. There are also, I'm sure as everyone also knows, there are lots of tools for patients and families as well. And so I just took a few snippets of some resources that are available across our fine country. And the same thing, I think they're really similar. They've got a lot of the same concepts. So one of the first sort of posters there, which when you get the slides I've hyperlinked for you, is, from our Speak Up National People campaigns that says, how do I do it? There are 5 steps. There's lots of videos to it. Think, learn, choose, talk, record, review. You can see that our colleagues in Manitoba have it in 3 steps: think, talk, and share. Nova Scotia has engaged with our Speak Up people, and they have their own Speak Up book. And in Saskatchewan, they have a booklet for patients and families as well called My Voice, which is actually the same here in British Columbia. So similar concepts, similar steps to advanced care planning. So just making sure that everyone understands and realizes that there's lots of resources out there, not just for healthcare providers in that realm of advanced care planning, but also for patients and families. So the second tool that we certainly are going to focus on is the conversation, the Serious Illness Conversation Guide. And of course, I couldn't speak to the Serious Illness Conversation Guide without giving Atul Gawande lots of kudos and putting his picture up there. I met him in 2016 in Boston. I was trained on the Serious Illness Conversation. I'm actually quite short, just in case people wanted to know, and he's very tall. So I didn't get a picture with him because he kind of intimidated me in many ways, but it was also his height. So anyways, he's written some books. The last one was called Being Mortal. If you haven't read it, certainly encourage you to read it. I would encourage you to encourage your patients and families and your own families to read it. And he certainly realized that he wasn't very good at conversations. He was a surgeon, he did surgery. So he engaged with some colleagues that he had and really started to learn from them. One of them was Susan Block, who is a palliative care physician, and she really helped him to understand that there were things that we should really ask patients, and she said there were 5 things, and we'll get to that. He also met another physician and really learned the phrase, "I'm worried," and we'll learn more about that in a little bit. So out of some of those experiences that he had, he developed Ariadne Labs, and that's where the Serious Illness Conversation Program was born, and where we certainly have all adapted originally from. So it certainly has gone through various randomized control trials. It's very, well-researched, tested language, and lots of tools out there that many of us across this country have adapted. So one of the first steps, certainly with the Serious Illness Conversation Program, is to identify who should we be talking to. So who would benefit from conversations and who is at risk. So in that context of COVID-19, this framework is from Fraser Health, and we talk about serious illness prior to COVID and said, it really is for people who have 1 to 2 years left of life. But gosh, now that we've got COVID-19, somebody who perhaps we should have been talking to 4 months ago, but we didn't think that really life expectancy wasn't that near, maybe we're prolonging that conversation. Well, now we actually really need to have that conversation with them. So in our framework that we use here, we really say who's at risk: people with chronic illness, people with serious illness, who actually, if they got COVID-19, now are really at risk. And I know, Jessica, that you also in Calgary Health have a lovely list of patients that you would also believe are at risk. And I just wondered if you quickly wanted to say a few of those.
Yeah, I mean, certainly people living with respiratory illnesses, heart failure, patients on renal dialysis, and anyone who's immunocompromised or living with cancer would all fall into that bucket B that you might not have thought about having conversations with before, but now is the time to reach out, either by virtual visits or in person.
Right. Thanks. Thanks for the details. Next slide. And I think that, we identify, and then we need to prepare proactively. We need to prepare patients and families and people that matter to them ahead of time. And again, there are a lot of tools out there that can really help help us prepare patients. So a couple of the tips that we've seen that are really helpful along the way are maybe provide the patient a letter that says we are going to have this conversation, just to give them time to think about it. These days maybe we're emailing that, but in some of our clinic settings, we've been providing that letter in our cardiac clinics as an example. I would suggest that we always review any documentation that might be sitting in paper chart somewhere or in electronic records. Where has that conversation been so far, and where can we go further with it, just to make sure that we've got some of that history. And there's also a resource that was developed by Dr. Amy Tan in Alberta as well, that I know that she's also found quite helpful, and I believe also, Jessica, you found that quite helpful to provide to patients as well. Anything else about the guide, or no?
No, except to say we'll make sure that those the hyperlinks get to attendees if you're looking for it.
Yeah, great thing. I think I put the hyperlink in there. So now that we've prepared the patient, and again, this particular tool that we're talking about is still a proactive tool. Now we really. So how do we do that? Well, I think a lot of organizations have adapted the original serious illness conversation guide to COVID. I know that the one up here is from Alberta Health Services. I've put the original one from Ariadne Labs. So review that guide. Look to see what questions are on there. Certainly in the teaching that I had with it, you're more than welcome to even bring the guide into the conversation, the actual piece of paper. And now that we're doing things a little bit more online, it's actually a little bit easier to have, like I do, a piece of paper in front of you. I would also suggest, and we would also suggest, that you review the clinician reference guide. In Fraser Health, we did a small adaptation to that clinician guide, as well as Ontario. The clinician guide, original one from Ariadne Labs, is about 20 pages. And although that number of pages doesn't necessarily scare me so much, I know that that is a lot of paper, and people might not have the time to read through all of it. So I think that, again, various organizations have put some smaller ones together, and really prepare ourselves emotionally for that conversation that we're going to have with people. Some people may be tearful. Some people may be, as we feel, in denial, or they might be angry. Prepare yourself. And again, if you have the time, which hopefully many of us can find the time, to review that clinician reference guide, because it really, again, helps with having some of that scripted language for how to respond when somebody has some of those emotions. Next slide. So again, in the reference guide, you can see that, what do you do when someone is angry? We're going to talk a little bit about the wish, worry, wonder. So in the response could be, I wish that this cancer had responded to treatment also. How do we respond to somebody who's tearful? What if somebody says they don't want to talk about it? Maybe a good response is, help me to understand more about that. So again, if you haven't had a chance to look at Ariadne Labs clinician reference guide, I would strongly recommend it. I really wanted to pay attention to also the little snippet here on the right-hand side, because although a serious illness conversation is not meant to get an order, for resuscitation or not. Sometimes those conversations naturally flow that way. And so we want to make sure that we understand that the conversations may exactly do that. So, we want to emphasize to the patient as well, though, that we want to make sure that we're going to monitor things, we're going to arrange things, but we don't want to say things, and this is where we've highlighted this, and I think it's important, but I think that we don't want to say things like, oh, we're just going to give you comfort care. I think our palliative care folks on the phone would totally agree, and certainly comfort care is a treatment. So but we don't want to say it's just comfort care, and we also don't want to be offering any treatment, let alone CPR, if it's not medically indicated, if it wouldn't be beneficial to someone. So I just thought I'd highlight that, and again, that clinician guide is really, really quite helpful. This slide is just a bit of a reminder that, when many of us across the country were looking at adapting the original serious illness guide, we took, a lot of their language and tried very hard not to change it, because it is so well researched and it's very, patient tested, and they've had those trials to it. So it is incredibly similar, but there are a few differences. And so one of them is to really make sure that we talk about uncertainty. So that's in sort of that third step. These are uncertain times. And under explore key topics, we also looked at, there are some things that maybe we should take out of the conversation and other things that perhaps we should put in. So just highlighting a little bit of that. A step 5 in the new sort of adapted guide, that the ones that I've seen have a new category or a new step called reassurance. And I certainly want to give Wallace Robinson from Providence Health out here kudos to that, because he was the first one who added it. I think that's really important. Certainly closing the conversation and documenting it is really important. So we just wanted to say, we tried very hard, I think, across the country to really stick as close to the guide as we can, knowing that in these times of not knowing exactly how COVID was going to land, and we still maybe don't, that we really tried to keep to the integrity of the original guide as much as possible. So these are just examples of the different guides that I found out there. Certainly Ontario, the one in the middle, has a proactive guide and conversation. We have one in Fraser Health, Alberta has one, Providence Health has one, and I'm sure there's probably some I've missed. So hopefully I'm not offending anybody of not being able to get everyone's on there. I was trying to make sure that we hit across the country. So those are just some of the guides that are out there. And so we're going to kind of flip back into Mary and say, now we really, we've identified her, we've prepared Mary, we've prepared ourselves, and now we're going to move forward and have a conversation with Mary. And again, through the guide, you will probably hear wish, worry, wonder, quite a bit. And so it's things that, again, from a patient tested language point of view, that really work. And I can say that certainly it works in my personal life as well as my professional life. I wish that things were different, and I worry that as a person with other health issues, you could get sick quite quickly. And I wonder if there are things that we could do to prepare. So wish, worry, wonder, it's something quick anyways that I can remember when I know with my staff, when I start to say, I wish things were different, they start all to get a little nervous about what's going to come out of me next. But anyway, so wish, worry, wonder. And we'll get on the conversation with Mary. So I just wanted to very quickly run through. I'm going to be having a conversation with Mary. It's probably going to be online, might be over the telephone or a video call. And I want to make sure that, I follow some steps. Again, knowing full well in clinical practice, it doesn't always go this way. It doesn't always flow. It doesn't get through all the steps. But ideally, we'd teach it like this, and we hope it goes like this. We really want to set up the conversation, and we want to ask permission. We want to say something to Mary like, I'd like to talk to you about COVID-19 and what's ahead for you in your care. And I hope that we can provide you with the care that you want if you get sick. Is that okay? We want to get that permission. We want to set up that conversation. We want to make sure that we're really clear ahead of time about what we're going to talk to Mary about. The next thing we want to do is assess her understanding and preferences. And what are those things? Again, these are just examples. For sure, there are lots of tools out there. But we want to ask her something like, what is your understanding of COVID-19 and how it's affecting people at risk? We might want to ask her how she likes to hear information. Does she like to hear information all at once? Does she like it in little chunks? Does she want somebody there? We might want to ask her in this area, you know, how she's coping. In terms of exploring, of sharing prognosis, we might in this area say something to Mary like, and I think you heard it a little on the slide before, but I'm worried that as an adult with other health problems that you could get sick quickly and that you are at risk for dying. I think it's important to prepare, you know, always allow some silence in there. In terms of exploring the key topics, you know, we want to ask Mary what gives her strength, what are her fears and worries, and we want to know if there's anything else that we need to know about her so we can give her the best care possible. Again, we want to add in this reassurance piece to say that our priority is to ensure that you're cared for and that you are comfortable. We want to close the conversation. We want to make sure that we paraphrase what Mary and others are saying to us. We want to say, I've heard you say that being with your grandchildren is really important to you. We want to say, I also heard that being independent is really important to you. That being at home and being independent is really important to you. We're going to make a recommendation, and it might not be a medical care recommendation. We might say, you know, I think it's important that we touch base again and talk about this again in another week or something like that. Mary is at risk, and we want to make sure that we keep up the conversation with her. Next slide. As a result of the conversation that I had with Mary, when we talk about documentation, these are again just some examples of a couple of forms that I might fill out and that Mary might fill out. So when I was thinking today about this, I thought, you know, Mary was having conversations a while ago. She was having conversations in the heart clinic with the nurse and the social worker, and so she was really prepared around substitute decision making, roles and responsibilities. And so after the conversation that I had with her, she actually hadn't done any formal appointing of a substitute decision maker. So, you know what Mary did? She went and she did a, you know, again, across the country, it's called something different. Here I picked Manitoba's, it's called a healthcare directive. And she's appointed somebody to be her substitute decision maker. It's her husband. We also think, though, it's important that the other people in Mary's life know what's important to her in case we can't get a hold of him, and also to support him, her husband, in the decisions. So we want to make sure that we've identified who anybody else would be in her life, that we would encourage her to continue those conversations. And in the middle is an advanced care planning record form or tracking form that some of us across this country have. And it's what I do as a clinician. I'm going to write down the conversation that we had, and I'm going to make sure that I've highlighted in point form some of the things that are important to Mary. So, you know, she wishes to avoid hospitalization. I think at this time that's probably something we're hearing a lot. Please don't let me go to the hospital. We're going to write down that not meaningfully interacting with her grandchildren and living, you know, independently. Right now, that Mary said that wasn't really acceptable to her. That doesn't mean we're writing something as an order. It just means these are some of the things that she said were really important to us. And she's worried. She's worried a little bit about not being as independent as she is. And so, you know, I guess, you know, in closing and sort of summary of my area that I was asked to speak to, I think it's the next slide, Jeff, you know, is just to say, you know, identify people who are at risk, do it proactively, prepare for the conversation, prepare yourself, prepare the person you're going to be having that conversation with. Have the conversation and document the conversation. And I'm really glad that, you know, next Jeff is going to talk about now what do we do with this information moving forward.
Thanks so much. Yeah, thanks, Cari. And I did want to say I tried the I wish worry and wonder once at home, and I got the no. Jeremy put the hand up, was like no with that, and then he walked away. So I'm not sure how effective it'll be at home for folks. So, you know, what I wanted to talk about in the next section is moving towards actual decision-making and goals of care discussions. And for the context of COVID, and then sort of we selected one area that I think is probably the crux of the most challenging aspect of sort of advanced care planning, goals of care, serious illness, but also the most important. And we'll get into that in a little bit of detail. And you know, Cari sort of alluded to this, but the similarities between the various types of conversations and the skill set that goes along with the various types of conversations, the overlap is tremendous. And what I wanted to juxtapose is the serious illness conversation, adaptation for COVID-19, and sort of a generic approach to the goals of care discussion, which again is really incredibly similar. And just to highlight that the share information, the exploring key topics, and the responding to emotion, I put it as in place of the reassurance, are much less of a linear set of elements, I would say, for the goals of care discussion in general. What I wanted to show you is just sort of the framework. Whenever I'm speaking about essential conversations, I like to have sort of root myself in, you know, what is the distinction between these big topics or these big conversations, because I think across the country there's a great deal of misunderstanding, misinformation about how we would define these, and I think Cari did a wonderful job at defining advanced care planning, and I think that it's still a work in progress. We don't yet have an international consensus. I believe they're working on it for goals of care discussion, but this is the framework that we're using in Ontario, and basing it on the importance of consent, right, and the shared decision-making process that goes into achieving consent for any care or treatment that's being offered. So if we're focusing then on the goals of care discussion, I have to give a shout out to Dr. Leah Steinberg and Dr. Nadia and Cardona here in Toronto, colleagues of mine, who, and the three of us have really spent many, many, many hours over the last couple of years really trying to suss out and tease out some of the elements of advanced care planning and goals of care discussion. And this was originally work that Leah had put together, trying again a couple of years ago to put some structure to this. I think, you know, when palliative care and palliative medicine really started to gain some traction and momentum in 2010-ish, you know, many of us were asked to help teach goals of care discussions. And it's a remarkably difficult skill to teach. And it took us a long time to figure out why that is. You know, it really is that middle section around giving information and exploring goals, values, hopes, and fears, and then applying that to actual, translating it to treatment decisions and applying those values in a really meaningful way, in a person-centered way, I think is the most tricky part. And that's what we'll spend a little bit of time, just 5 minutes or so to do that. So we have another poll for the group, and hoping that that can get launched. I'll read it out. You have a debilitating motor condition and are offered a medication that allows most patients to function independently. However, most patients also experience a 30% reduction in cognitive function. Would you take the medication? I think, Jess, there was 250 or so for yours, and so we'll see if we get close to that. Interesting, starting to wind down a bit. That's great. So it's about 2/3 and 1/3, and you know, of course, there's no right or wrong for this question. The point is that there's going to be wide variation even amongst clinicians in this group in terms of the perspective on this. And so, thank you so much for the poll. To build on sort of that information, I want you to think about what you just did. How did you come to the decision, right? It was very quick. You immediately were able to know what went through your mind. And what I'm imagining is that you actually understand what those words mean. You understand what 30% reduction in cognition means. You have an image of what life will look like. What you also have is an image of what's acceptable and or intolerable to you. Acceptable or unacceptable, tolerable or intolerable. You compare those two images in that moment, and you're able to say yes or no. Right? This is what I would want. This is something that I would not want. That's how you arrive at a decision. You're comparing these two images, and really, what is acceptable, an image of what life, an acceptable life, that is what you value. That's a statement of your values, a collection of your values, and what's important to you. So, sort of doing a bit of a reverse kind of approach to pointing out how values can shape decision making. The challenge is that the rest of the world does not understand necessarily what 30% reduction in cognitive function looks like, what that means. They don't envision, people that are not in healthcare don't envision their future in terms of treatments like cognitive function or FEV1 or tumor burden or renal function. They think about outcomes of treatments, not treatments themselves. They imagine what life will look like and how their life will be impacted by illness and treatments. And for example, spending more time with healthcare providers than family or friends, perhaps not being able to communicate with family or friends and repeat emerge visits as the impact of illness and the actual important things that are considerations for the rest of the world when they make decisions. So, you know, the bottom line is that people don't have a sense of what life will look like. And our job, I would say, as clinicians is to paint a picture to the best that we can of what life will look like so that a person can compare that with their own image of what's acceptable, what's tolerable, what's not tolerable on the left. So when you kind of pull this all together, there's really two sources of information that goes into a decision. There's information and evidence about the disease and about treatments, and then there's information and evidence about the person, what's important, and almost more importantly, why it's important to people. Both of these sources of information are needed for decision making to be effective, is the bottom line. We do great on the blue side, the right side, in getting through treatments. We don't do so well when it comes to people understanding their illnesses, their diseases, and just as important is the left side. You know, the how the person can contribute to that decision making process. It's incredibly important to listen or to pay attention to both. The question is how do we actually do that? And that's where that's the tricky part, I would say. But coming back to this model of goals of care discussions, the give information really is the information about the disease or the treatments, and then the explore goals, values, and hopes. That is the person side of things in this. And so if we really think about this model of goals of care discussions, it's preparing for the decision making that occurs subsequent to this by ensuring that the person, that you yourself are prepared, ensuring that the person has an accurate understanding of their illness, that sort of interplay between giving information and getting information about the person, and then making recommendations. And sometimes the recommendations may be to pick up tomorrow where we leave off today, because we're still at illness understanding. We've got some things to sort of sort through before we arrive at a decision. So, this is just sort of meant to be a bit of a framework for how we actually would approach the goals of care portion of, a shared decision-making process. So bringing some COVID into this then, I just wanted to give an example of some COVID-related information that you would be giving during the discussions that you have. And so I put up just a quote here that explains a little bit about COVID-19. And I think what's really important about COVID that's, I think, quite different than, or maybe actually it's not so much different than our pre-COVID days, but it was made really obvious the distinction between mild and moderate and serious illness for folks that have serious COVID, and the different kinds of conversations that we needed to have, whether a person was at home or in the hospital, and the severity of the COVID as well. Many times these were, when we spoke with our colleagues in New York and in Italy, these were not goals of care discussions. They were breaking bad news discussions in many ways. And so, you know, I think now that we're sort of shifting a little bit in terms of the intensity and severity of COVID, we're able to think back now around ensuring that a person's goals and their values are actually shaping and informing decision making. When you are having COVID-related conversations, though, I did want to point out this wonderful visual from Amy Tan in Calgary, because I think what this does, this is a kind of visual is relatable to people. I think numbers in general are not relatable to many, but I wanted to put this up there because it's a fantastic example of how you can, in an instant, sort of communicate what happens with intubation and what happens with CPR in folks that are in hospitals. So this is just a really great example that I wanted to highlight. And then two stats that are also from Amy Tan's resource around folks that are above a certain age, and then the survival rates from both ICU and CPR. So I think these are digestible nuggets of information that is important when it comes time to making decisions like code status or critical care or escalation of care in general. So, you know, in my last sort of slide before I turn it over to Jess and we open it up for questions, just coming back to Mary then, if you look at the original statements that she made during the advanced care planning conversations, she does actually understand that her heart failure, she understands that it's incurable. She doesn't understand the trajectory being progressive. But she notes that that independence and not being burned are the most important things to her, which is a really common perspective. But it's her worry about not being able to play with the children, because she values that the greatest, and not being able to live in her home. And so I think if it came time for her husband to be making decisions, you know, those are the kinds of questions that he's going to be looking to ask and seek answers around. Is, you know, will this treatment actually allow Mary to, is it more likely that she'll be able to play with her grandkids? Is it more likely that she'll be able to live at home as a result of this treatment or care approach? And if not, in many ways that, you know, her husband will have the answer right there. So, you know, this is how that information can be applied in various kinds of decisions. Whereas I think some of the previous work many years ago, when the focus was on sort of code status as an output of advanced care planning, then that singularly focused on that specific decision and missed out on the opportunity for the many decisions that can be driven by the values-based advanced care planning conversations that we're having. So with that, I'll turn it over to Jess.
Thank you. And a couple of chat questions about, can people access the information and the trajectory slides? Absolutely. These will be available on the Pallium resource, and Erin can remind us how to get to that. But you can also find a lot of this information open access online. So Speak Up is the national resource, and you can click to find healthcare professional information for each of the provinces, because of course our legislation and our medical infrastructure is different from province to province. In Fraser Health, you'll find the COVID-specific documents as well, and at Hospice Palliative Care in Ontario, and at Conversations Matter in Alberta Health Services. And on each of these web pages now, you'll find a little button that takes you into some of the COVID communication adapted tools. And we will be emailing participants with details about how to access slides afterwards. So, Erin, should we hand it back to you and then on to some questions?
Sure, no problem. Thank you so much, everybody, for the valuable insight that you have shared into this topic. As I believe one of you said earlier, I learned something new every time we discuss this topic, which is wonderful. So we've had some really great questions that have come in through the Q&A, and many of them have been answered already. So I would encourage you to please look through those typed out answers. And what I'm going to do now is try and ask some of the more in-depth questions to our panelists. And I would encourage all of the panelists to answer the questions if you feel the need for giving your input. Cari, I'm wondering if you could speak briefly on just some of the importance of referring to your own provincial resources for things like ACP. You know, why is that important?
Sorry, what's the question again? I didn't really.
Yeah, just making sure that you're looking at your own provincial resources.
Oh, I see. Yeah.
Yeah.
Sorry, I misunderstood the question. That's why I clarified.
Yeah.
So, you know, across Canada, in our provinces and territories, you know, we do have different laws around consent, and also some, you know, some documents, as an example, an advance directive, which is a very specific legal document, is available in British Columbia, but it's actually not available in Ontario. So I really feel that it's important that we, you know, I think there's a lot of similarities. I actually think there's more similarities than we think around those steps of a conversation, around the principles of it. But when it comes to actually the formality of, you know, completing any legal documents, we really need to be mindful that we're, you know, stepping within our own jurisdiction. And there's my pipeline for, I think we need national legislation to this, because that just sounds silly now, doesn't it, to say everybody look at their own. But anyways.
There are two fabulous resources recently added to the Speak Up website, and one is all of those laws summarized for you province by province in a sort of legal toolkit, and then the other is for patients and the public and families, and therefore for us as healthcare providers too, that lays out what's happening from province to province. So definitely you can find what you're looking for.
That's great. Thank you for sharing that. Jeff, I'm going to ask you this question. It's a bit of a spin-off of one of the comments that one of the participants made. You speak of info and evidence in your diagrams, and you know we tend to be really great at that part when we're talking to patients. But in a time of COVID, where so much is changing so rapidly, right? Policies, what people have access to that they, you know, maybe don't now, but used to, you know, how are you managing with that when you have these conversations with people, this level of uncertainty?
So, you know, I have to be honest, in not being in emerge, not being in critical care, I think those are a certain kind of conversation that happens in that sort of context. I think what COVID has underscored is, and really sort of shone the light on, is the opportunity for advanced care planning. Information and evidence can be of the person, right? The person's information, the evidence of the person. And so, you know, because it's almost, the point is that we're not going to be able to prepare for necessarily for the kinds of interventions and treatments that may or may not be available to a person. So I think to the extent that we can proactively be having conversations with patients, they want to be having these conversations. They're very relieved when they're contacted by their family physicians or whomever to begin sort of these discussions. And I think the more we can do ahead of time, which has always been the case, right? But the more this has really just amplified that, will allow for a balance in the uncertainty and the when the time comes to actually making decisions. I think that's been the most stressful thing to observe in my colleagues, and I know the webinars from New York, it was staggering to me, our palliative care colleagues in some of the more challenging places, when they were needing to when day to day it differed, right? The kinds of resources that were available and how they actually navigated that. So I can't say that I have any helpful tips for in the moment when you're in the emerge, but I do think that it's incumbent upon us all to do what we can ahead of time. I don't know, Jess or Cari, do you have other thoughts on that one? It's a great question.
There are a few fantastic questions coming up in the Q&A, and encourage everyone just to keep typing. A couple people just wanted to know what a green sleeve was, and then a few people are sharing some of the ways that programs in their country make information available across different care sectors. So a green sleeve is literally a plastic folder that we keep the advanced care planning and our goals of care discussion and so on documents in, and that is the property of the patient, and it travels with, and they bring it to hospital when they come. And that's one way of making sure that information doesn't get lost in healthcare records or locked away in clinics after hours. Somebody's typing from Nova Scotia that they have a different system that lets the electronic health record or people can register their goals of care ahead of time, and the ambulance system can access that information. So you can certainly learn from different practices across the country if your own system doesn't have ways to convey this information. One of the best things you can do, of course, is preparing the patient and their advocate, their decision maker, so that if they don't have those pieces of information with them, they can still say, you know, we talked about this before, and this is what Mum told me is really important to her.
Mm-hmm. Mm-hmm. Yeah, we've got green sleeves in British Columbia as well, in Fraser Health mostly, but yeah, one in the chart and one that goes on people's fridges.
Can I just add one quick thing that's a complete tangent? For our pyramid, I have completely forgot to give a shout out to Nova Scotia, the entire province of Nova Scotia, because they did this wonderful job at identifying a pyramid, and I needed to give them credit and full kudos for that. So thank you. When you said Nova Scotia, Jessica, I was like, forgot. So thank you.
Okay, great. So we'll go on to another question that was posed earlier while you guys were speaking, and that was, you know, it's seen by a lot of people that dying at home with COVID is not a possibility. It's too dangerous. People are scared, you know, families don't necessarily have the correct PPE, for example. You know, how is this changing the conversations that you guys are having? And again, what advice do you have when you see fear as being such a factor, and then sometimes realistically being at home is not an option, but then you have these visitor policies that, you know, people are so scared of, so they don't want to go anywhere actually.
Maybe I'll just really quick. You know, the numbers of people that are dying at home have gone up substantially in April and May, at least in the GTA and the Ontario region. So I think it really reflects a comment that was made around people not wanting to or wanting to avoid coming into the hospital. And I would say that for my context specifically, it actually, the visitor policy has been unbelievably time consuming and complex and tricky, and a key decision making factor when it comes to PCUs. Our PCUs have not been at full capacity, and so that's been a real struggle for families and for patients to wrap their head around. So we've actually seen more people dying at home as a result.
Wow, amazing.
Yeah.
Yeah, and it would be the same as far as I understand it in Fraser Health. Most people are opting not the hospital or even hospice route due to some of the visitor regulations.
Yeah. Thank you. Cari, I'm going to ask you this next question, and it's two-pronged, okay? Because you had mentioned you had mentioned at one point that like you could even read off a script, you know.
Yes. You
know, so lots of people that have had practice with these things, they can, you know, they have their own style. Reading off a script would feel awkward.
Yes.
You know, how realistic is it to actually, if you're starting to have these conversations, to read off a script? Are patients, you know, deterred by that? Or I'll ask the second one after you.
Okay, good, because I won't remember. So it's a great question. And I have to say that it's one we get asked a lot, because we do a lot of teaching around serious illness even before COVID in Fraser Health. And I think that what I see, and I don't know if it's going to be Jessica and Jeff's experience as well, but people who, clinicians who do have experience and maybe they've got their own expertise to it and have their own words, do find it hard. However, when you actually ask them to engage in actually using the script and using it in exactly the way that it was intended to do, they're actually, they become believers. I have somebody on my team who I'm sure is on the line who says he initially wasn't drinking the Kool-Aid, but that the more that he uses it and the more that he sees his colleagues use it, the more that he understands how you know, how much it really does work. I think that it comes down to saying to a patient, I've learned a new tool. I mean, we have to think of this, it's an actual intervention. It's a tool, it's an intervention. It is as important as wound care. And as soon as we start to see it like that, then we can say to patients, I've got a new tool and I'm going to bring it in and we're going to have a conversation. My understanding from anyone I've ever spoken to is patients are not adverse to that whatsoever. The other story I'll just quickly share is, you know, you know, I won't call her out, but I've got a dear friend on the island who's a nephrologist who said the same thing. We were together getting trained with it. And she said, I can't imagine using it. Like, it's great, but I can't imagine using it. And when we came back from Boston, she had a tricky situation with kind of a tricky family, and she used the guide, and she said, she called us all and said, it works. Like, I can't believe it, it works. I'm in this situation and I really didn't know what to do. And I said to them, I'm going to bring this in. I'm going to go through it word for word. And she said it just really helped the conversation flow in a way that it didn't go off on different tangents. Not that conversations can't go like that, but so I hope that answers that, the first part of that anyways, that I think we asked permission to bring it in. And I think that even clinicians, palliative care clinicians particularly, feel that they're very skilled in this area, and I'm not saying they aren't, but try something new, and maybe, you know, even if you use it and you take the odd phrase out of it and it really works, I think it's really beneficial. What was the second part of the question?
Yeah, so the second part, again, is my attempt to combine some of the questions that are coming through. There's so many great questions, but so we have these tools, we have these things in front of us, but what are really great places to go to see these in action? So, you know, with some scenarios where you can see virtually, you know, perhaps somebody dealing with family conflict, you know, where a husband and wife doesn't agree, or I mean, you could think of 1,000 different scenarios, but are there any really good virtual teaching tools out there? And I open this to any of you to answer.
Yeah, and again, it's a great question. I'm going to sort of start at the top of the list, and then I'm sure that everyone can go down, but Ariadne Labs has a community of practice, and I would suggest that people who are interested in this area join their community of practice. They have a lot of teaching videos, so I would encourage people to look at those teaching videos. Certainly in the education that we've been doing around serious illness, we have been doing a lot of role plays, but bear in mind that, again, even when we were doing advanced care planning, we were always doing role plays. Our challenge now is that we can't get together in a room, so I'm not sure how to solve that problem exactly, but I think the videos are quite good. But I also know that other local jurisdictions have made teaching videos that I'm sure are just as good, you know, so I would encourage people to look at that. And if it's something that you're interested in as an organization, I'm sure we can get a list together. I'm pretty sure that Providence has one, and Jessica or Jeff, I'm not sure what else you know of out there.
We've been using that Providence one and the Ariadne Labs ones, and there's lots of great snippets of it on the Vital Talks website. So a little bit of Googling and you probably find what you're looking for if you're trying to give virtual sessions.
I think it's really hard with scripted, you know, acted out. There's something about the realness and nuance that is so hard to capture. I always struggle with just sort of the authenticity and trying to suspend disbelief with them. So I get the question because it's tricky.
Yeah. Well, and I
refer people to the great resource from trying to buy, is it Nadine
Katie Marchington did a wonderful goals of care video, and I think we're really realizing the role for simulation in actual professional development, and having that real life experience to the extent that we can. That's what we're starting to shift towards in terms of trying to really build skills around this.
I can share experiences teaching it to residents, and we use the breakout room function on this
on Zoom,
so that people can go and practice having conversations virtually in small groups, 2 to 3 people at a time, because the simulation is so important. There's no getting around the need to practice these conversations before you have them with real people.
Absolutely, yeah.
Well, we're getting pretty close to needing to wrap up. Jessica, I'm just wondering if you were, if there were any burning or really important questions that you felt like we needed to address for this portion that maybe I missed or didn't see.
I just think a lot of really difficult situations that people are facing that are coming out in the questions is that a very challenging situation where the patient wants one thing and a family member wants another, and how to address that. I don't know, Jeff, do you want to quickly speak to that?
Oh, do you know, we actually, some of the Nadia and Leah worked on a specific resource around that. And so probably would just, the most efficient thing would be to direct folks to the Speak Up Ontario website, because that is the greatest challenge. And I think to do its service, but yeah, I was just suggest go and have a look at the resource because it's really well done.
I mean, it does come down to, doesn't it, listening to all of those voices, and if you can, hoping to facilitate for the family member to hear the patient's voice directly.
Yeah.
And then so many of these other questions are about that challenge, about not being able to have patients and family members in the same facility or room, same physical space at the same time, and how we've all had to adapt to that added moral distress, but using, again, our phones or whatever way we can to connect people so they can still hear each other, even if they can't.
Yeah, and I think the even greater challenge is when a person's goals don't align with the resources that are available, and I think that's the thing that we were all preparing ourselves for, and hopefully that won't become much of an issue, but that's an even greater. And that's a breaking bad news versus, what are your values, what are your goals?
Yeah, Jeff, that's been another theme in the questions for sure, is being about that. And, speaking of all these nuances and family conflict and, reading off of scripts and things like that, I think I'll just close by saying this is a plug for me, for my family medicine colleagues, right? It is so important that we have these conversations with our patients, because we're the ones, for the most part, that have the, intimate knowledge of the patient and who they are and their social context and who their family members are. And so really paying attention to this moving forward, I think, is going to be key. Yeah, and with that, Jeff, I'll hand it over to you to wrap up our session today. Thank you, everybody.
Thank you so much, Erin. And a big thank you to all the panelists for the time they put into preparing for this webinar, the engaging dialogue, answering the questions. You folks are wonderful. Thank you so much for your contributions. Thank you to our participants. I thought a lot of great questions came up in today's webinar. And a big thank you to the Pallium Canada team behind the scenes that make this webinar happen and function flawlessly. So thank you, team. For the participants in today's webinar, you'll be receiving an email with a survey. Please fill that out. We only get better from the feedback that we receive from you. And in about 24 hours, this webinar will be uploaded to pallium.ca. Visit pallium.ca to get all the resources related to COVID, the webinars, the free online modules. And thank you again for your participation. Have a good rest of your day. Stay well, stay healthy, and we'll see you on the next webinar. Take care.
Thanks. Thank you so much.